just positioned behind the transverse pericardial sinus, which is borderly anterior by the aortic sinuses, and also the posterior wall of the LA is just in front of the tracheal bifurcation. Because the SVC and IVC enter at angles, the posterior artery is slightly indented. That indentation in dogs is even more sharper with a distinct fold that can be seen inferior to the entrance of the SVC. And in fact, that is what is called as the tubercle of lower. In dogs, because why I'm talking, because sometimes few people also have to deal with such anatomy as well. So what happens is the musculature of the RA extends up to 1 centimeter into the SVC, in fact, okay? And that is why what happens further is the atrial septum runs obliquely from the front, extending posteriorly and to the right. And the pulmonary veins join the posterior part of the LA with the left pulmonary vein orifices, which is more superiorly oriented than the right pulmonary veins. Okay, don't forget that. In fact, in humans, it is most common to find two orifices of each side. Sometimes two veins on one side can be united, so that is what is the common os, what is called as common os is in fact important to understand, because a lot of times what will happen is whenever we are ablating or targeting the pulmonary veins, we can notice that, and that's where the problem is going to happen. And the coronary sinus, which is continuation of the great cardiac veins, is located posteriorly and inferiorly to the LA and is in the left atrioventricular groove. And the oblique vein of Marshall, which is located between the LA appendage and the left superior pulmonary vein, the post-inferior pulmonary vein runs inferiorly along the inferior atrial wall to join the CS. And in fact, in most people, yes, this vein is obliterated. So what we can see in this figure further is about the different pulmonary veins, okay? Close to the PV LA junction, the sleeves are more thick and completely surrounding the epicardial aspect. The distal margins of the sleeve are irregular as the musculature fades out, and the sleeves play a sphincteric or mechanical role, in fact. And in the LA, there is no terminal crest, so the pectinate muscles have nothing to anchor to. However, few people do have different thinking as well. But on an overall basis, they are less regular than the RA, and also the LA looks more smooth, but is made of like 1 to 3 layers of overlapping layers of differently aligned myocardial fibers with marked regional variation in thickness. So we are already aware of what is called as the Buckman's bundle. Buckman's bundle crossing the anterior interatrial groove, branching towards the RA and the LA appendage, and joining the superficial circular fibers, passing the left atrial wall. So that is what tends to happen. And further, what happens is, if you look carefully, there is also the longitudinal fibers of the septopulmonary bundle in the posterior wall of the LA and superficial circular fibers in the inferior wall. So this is what you should keep on having a look over here. Yeah. So the view from the superior, how does it look from the anterior? So because the heart is a three-dimensional structure, it's not a, just anterior, posterior. So we have to look on an overall basis. So even if you will, there are also subepicardial fibers in the LA dome as well. There is some if you will try to have a look in the subendocardial view with the interatrial and septopulmonary bundles which are removed. So in that, then we are able to notice these fascicles as well. Okay, so these fascicles which are running closely across the dome as well over here. So the orientation of these fibers can be different at different layers. This is what has been tried to emphasize in these figures, in fact. So that is why lot of times AF ablation is not so simple, which a lot of people may claim because of this difference in the orientation as well. So the wall is what is which is being attempted for the ablation, right? And if they are going to be different thickness or at different levels, so of course you should be trying to deal with them in a different way. And if you don't deal with them in a different way, that is where we are going to land up in problems, right? So that is why it assumes its importance that we have to deal with them in a different. Otherwise, the problems are going to be there, right? So that is why we have to be careful. What are we doing? How are we doing with these pulmonary veins, right? Has anyone come across, did you all see anyone of you like AF ablation? Anyone has seen AF ablation or not? No? So no one has seen AF ablation. So in AF ablation, what happens is they try to target those left-sided pulmonary veins. Yes, although for 25% of the triggers, they also explore on the right side as well. But majority of the times, they attempt to target on the other side. So this is what I was telling you. So if you look carefully in the different orientations of the pulmonary veins, you will be yeah. So you will be able to notice the different orientation of the pulmonary veins as well. So then comes is the ligament of Marshall. Ligament of Marshall is the oblique vein of the left atrium which descends along the back of the LA and ends along the opening of the great cardiac vein. This is sometimes the origin of atrial arrhythmias. In fact, the vein of Marshall is a vein closely associated with muscular ligament, which results in the potential for ectopic sites to occur from there. The veins of Marshall travels very close to the left pulmonary veins and also can mislead doctors to thinking the ectopy is from the left pulmonary veins, when in fact it is from the vein of Marshall. So that's why the CS catheters with lumen can be helpful to inject contrast dyes to visualize the vessel and either to cannulate it, otherwise to assist in inserting mapping wires to map for the ectopy occurring from within. And CS, so now I hopefully you are able to understand what is its importance. So what happens is, other than this, in this view, if we look carefully from below and behind, so what is called as the diaphragmatic aspect. So we will be able to notice a lot of structures, vital structures, in fact. So this, in fact, the coronary sinus is the one which drains into the base of the RA and is used for normally a decapolar catheter insertion to evaluate the conduction between the LA and LV. And CS is the actual part of the CS os in the branching of the vein of Marshall. From there, in fact, on it's called the great cardiac vein. The vein of Marshall travels next to the left superior and inferior pulmonary veins. The SVC travels next to the right superior and inferior pulmonary veins and the pulmonary arteries. Especially the left pulmonary arteries are the ones which tends to travel within the close proximity to the left and right superior pulmonary veins. Thus, by placing catheters in those structures, far-field signals can be recorded from the pulmonary veins as well. So that's why EF ablation is always more of a tricky case. It's not the easiest, but it's slightly difficult as well. So one have to be master in the cardiac anatomy. Okay, and the posterior vein of the LV is often targeted for the placement of a biventricular pacing lead as well. Similarly, the RC courses between the RA and the RV and the conduction between these two structures can be evaluated by a mapping wire in the RCA. And the middle cardiac vein courses between the RV and the LV on the inferior aspect. So that's why its course is very, very important. Whenever the patient has an epicardial pathway located in the posteroseptal region, the pathway can be assessed to ablate this using this pathway. In fact, yes, the problem is also it's close to the PDA, so posterior descending artery, so one has to be slightly really careful as well for this. So there are various studies which has shown about those, there are portions of the myocardium surrounding the coronary sinus. So that is why a lot of times, there are some direct connections between the CS musculature and also the ligament of Marshall as well. So there are several theories which have said or proposed that some portion or some incidence or origin of the triggers of AF tends to happen from the ligament of Marshall as well. So this is more of a pulmonary venous angiogram, and when it is being seen, so we will be able to pinpoint the different branches and sub branches also of the pulmonary vein as well. Let me see if this plays. No? Come on. Okay, so this is more of a CT angiogram. So with using a CT, how you are able to make it out. So this is during the procedure which has been done. Okay, and none of them is actually having a close resemblance of the contrast using the CT angio. So that's why before the procedure is done, a good image should be taken of the pulmonary veins to avoid confusion, unless until one is really confident, of course. So what happens is, until a recent report on 4 patients which experienced pyloric spasm and gastric hypomotility after undergoing the catheter ablation of AF, especially in some of those cadaveric materials as well, large bundle of anterior esophageal plexus passing external to the pericardial sac, but in very close proximity with the LF wall and to the right and left venoatrial junctions, so which can be seen in the figure as well. So this is the reason a lot of times what happens is whenever the pulmonary vein, pulmonary venous ablation is being done, there will be patients who there are patients who have even developed atrioesophageal fistula, because it is indeed close to the esophagus as well. Yeah, so that's why a lot of times some people tend to do a posterior translocation as well. For example, trying to avoid it or trying to be a little bit extra careful whenever this procedure is being done, especially for such patients. So now, in this, they are trying to show the proximity of the right inferior pulmonary vein and how is it located to the different vital structures like the lung or the esophagus as well. So, and over here as well comes the vagus nerve. So that's why a lot of times if you are ablating in this area as well, you may be causing damage also to the vagus nerve. So this is a very beautiful microscopic slide of that region, in fact. So in this, you are able to notice about the coronary sinus. In fact, the great cardiac vein leading to the coronary sinus encircles the mitral leaflet of the mitral valve, and the CS is positioned in the AV sulcus between the LA and LV. The CS catheter, if of small French size, like 4 or 5 French, can easily reach the anterior CS. If it is of larger size, it will have trouble doing so. The accessory pathway can occur anywhere along the dotted line. So that's what we have already shown, these dotted lines as well. And they do not occur septally to the anterior septally around the mitral valve because of the central fibrous trigone. And this is in contrast to the right side, in which the accessory pathways can occur anywhere along the tricuspid annulus. Okay, so that's why it is very important. So whenever you are trying to ablate a accessory pathway, where should you be looking actually to ablate, or where you should not be looking actually to ablate? So due to the highly trabeculated wall of the RV, the stability of the RV apex catheters placed in RV is very good. However, due to that trabeculations, large franchised catheters, they do have trouble making contact with the RV wall. Please note the moderator band. In a healthy heart, that will be very small or almost non-existent. In fact, this is a muscular structure assisting in the ventricular contraction, so with the RV dysfunction, and this will be large since it must work harder. And that is why sometimes in pacemaker implants, the doctor cannot get the RV lead into the apex. And also to note that the right bundle branch also passes through the moderator band, and when one is present, okay, so we should be able to also differentiate the right ventricular outflow tract. Especially in the LV anatomy, if you can see in the figure well, when we are comparing the picture with that of the RV, the LV is much thicker. Thus, the innervation also needs to be far greater, and that is the case with the two large fascicles seen in the slide with the normal conduction system. You can also notice that the attachment of the tricuspid valve is lower than that of the mitral valve, and thus you have a portion of the LV that is directly in contact with the right atrium. This is where the membranous septum is located, and it is composed of atrioventricular and interventricular portions, in fact, and the AV part is the one near the RCC. Yeah. So this is again another beautiful cross section. So different areas are marked well: RVOT VT for the LVOT VT, the LV septal VT, and for the inflow area. Inflow area is the one close to mitral annulus or the tricuspid annulus. So what happens is the left and right sided VTs, the LV is the one side for a lot of VTs as well. The outflow tract is the area which can be located on the LV outflow tract or the LV epicardium. This can be ablated from the aortic sinus of Valsalva. Another site is the LV inflow annulus, which is near the mitral annulus. And the last LV site is the LV septum, located in the inferior septal region. This is the difficult site for ablation catheters to deflect adequately to obtain the good contact. In the RVOT is a common site for VT. Occasionally, the ectopic site is located past the pulmonic valve in the pulmonary artery. Because the RVOT is a tubular structure, it is ideal for the use of a spiral type catheter. Often, doctors use the EPT constellation basket catheter, but the splines on that catheter are far too apart to do the detailing. And that is why to position those catheters, SL2 is the one best choice. Or SR0 is very helpful to direct the catheters into the RVOT. Yeah, so this is very important. And moreover, since the ablation catheter stability is poor in the RVOT, that's why sheath can be of very much helpful and should be promoted as well. So so this is how is the beautiful CT angio of the heart, and to do a EP study, especially in different cardiac anomalies as well, it is very important to with the congenital heart disease, left to right shunt, right to left shunt, obstruction, and other defects as well. So even in the congenital heart defects, they are the structural anomalies of the heart and great vessels which is present since the birth, and most are amenable to surgical repair with good result and long-term survival. And scarring from the surgical repair is often the origin for the tachycardias. And as we all are aware, most CHDs are shunts or obstructions. So that's why a shunt is one abnormal passage between the heart chamber and the blood vessel. And the shunt will, of course, permit from left to right or right to left depending upon the pressure. The left to right shunt will redirect systemic flow from the pulmonary circulation and expose the patient to increased pulmonary pressure or volume. And the right to left shunt is going to redirect poorly poorly oxygenated pulmonary circulation into the systemic circulation, and that is the one which is going to cause the cyanosis, causing further paradoxical embolism, in fact. So these are some of those examples of the left to right shunts. So it's really, I would really like you guys and girls as well to go through these details. So it is already mentioned really well. Similarly, there are right to left shunts as well. If we look carefully, like those TOF, TGA, TA, and TAPVC as well. Similarly, for the obstructions as well, it can be through the coarctation of aorta, pulmonary vein stenosis, and also the aortic stenosis or the atresia as well. Other than that, there are some other congenital abnormalities as well, like the Epstein's or also the dextrocardia as well. So I would really like you all to spend some more time about it, trying to have a look, trying to understand as well, to have a better understanding of this, what is happening around, yeah?